Assalamu alaikum. I'm again here. I'm Dr. Nas with online video lectures of cardiology. Today we will complete our remaining task, that was the remaining portion of the non-ST elevation MI, the management of the non-ST elevation MI. As you are watching here that we have 4 drugs over the board. These are actually the antiplatelet drug therapies which I actually need to discuss with you guys, because these are the very essential drugs in our cardiologies, and I actually want to discuss about their mechanism of action, the pharmacodynamics, the onset of their action and their life, and their about their half-lives and the total life of the drugs, and their trials, dosages, side effects, and the contraindications accordingly. So first of all, as you know that the aspirin is the blessing in the cardiology. So actually what aspirin does, aspirin is COX-1 inhibitor. It actually blocks the COX-1, it actually blocks the platelets by blocking the COX-1 inhibitor, and by blocking the COX-1 inhibitor it actually blocks what? Thromboxane 2. So thromboxane 2 actually activates the platelet aggregation of the platelets. So if you are blocking the COX-1, actually you are blocking the thromboxane A2, and by doing this you are actually blocking the action of platelet and the aggregation of the platelet at the plaque rupture. So thromboxane production actually does in 15 minutes when you will take the aspirin, and the total platelet inhibition after taking this aspirin, after taking of this aspirin of 60 minutes after taking this aspirin, you will get the platelet inhibition, and that platelet inhibition will remain there up to for like 7 to 10 days, because it irreversibly blocks the platelets at COX-1 site. Okay, so the onset of action is actually 60 minutes, but its half-life in the blood is 24 hours, but its total life, like it inhibits the total lifespan of this drug in the blood. If you will not take this drug, and if you will like stop today aspirin, if you will stop taking aspirin today, so the effect of the aspirin will remain for 7 to 10 days. So the total life of the aspirin is 72 days, but the half-life is 24 hours. So why aspirin is very necessary, very essential in cardiology, and is a blessing for the cardiology in our ischemic patients, because it gives 50% mortality benefit. This mortality benefit is given by so many trials, but actually the 50% mortality is given by the meta-analysis of so many trials which was done on the aspirin. So the loading dose of aspirin, as you know, is 162 milligram to 325 milligrams, and the maintenance dose is 75 to 100 milligrams. But in Tica, as aspirin with Tica, the high dose of aspirin with Ticagrelor gives the risk of bleeding, which actually was told by which trial? It was given by Plateau trial. So the guidelines suggest that give the only 81 milligram of aspirin if you are giving Ticagrelor to your patient. So the very next and the very conventional and the old drug we have is the Clopidogrel, which is actually the P2Y12 inhibitor. It is again an other antiplatelet drug. It actually blocks the action of platelet at the site of P2Y12 inhibitor by blocking the ADP. So it actually blocks the platelet walk. So it is the prodrug. It has to be activated, it has to be active drug in the liver. It is metabolized in the liver. So after metabolization in the liver, this drug becomes an active drug. So if you will give it in a normal loading dose of 300, it gives you the rapid onset of action within 2 hours. But another trial told us, Armida 6 trial told us that if you will give and if you will use the 600 of dose in a loading shape or in the loading dose, so it will give you more rapid onset of action, and its half-life is 24 hours. That's why we give it once in a day, and it's the whole life, like the total lifespan of this drug is in the blood is 5 to 7 days. So that's why you need to hold the clopy before going for the cabbage, like before 5 to 7 days. So the why it is very much important, because it has a aided 20% mortality when you will give this clopy with aspirin in your ischemic patients. So it is a mortality benefit. Cure trial is a positive trial for the Clopidogrel. As you know, there is a very famous trial. PCI cure trial told us that you have to give the Clopidogrel before PCI and after PCI, and it actually gives a mortality benefit in our post PCI patients. So the Credo trial again tells us that you have to give the 300 milligram of your Clopidogrel to the patients who are actually going for the PCI, or they are coming in the ER with the acute ischemic events. So Armida actually told us that you have to give the 600 in the loading dose, because it would give more rapid action, onset of action in your patient. The side effect, with the very notorious side effects of the Clopidogrel, which most of the people are actually unknown to it, that it is urticaria, bleeding, and TTP, thrombocytopenic purpura. So it is rare one, but it actually occurs in your patients. So you have to, if your patient is presenting with the low platelets, and if the history of bleeding or all these things, if he or she has a history of itching, then you need to rule out these things in your patients who are taking Clopidogrel in a DAPT. So the very famous, and it is not new, but yes, it is new in our country, like in Pakistan, that Tika, again it is a P2Y12 inhibitor, and it is potent platelet inhibitor. It is actually active drug, that's why it is potent. Its onset of action is very rapid. It actually inhibits and block your platelets within 30 minutes. So its half-life is 12 hours. That's why we give this drug in twice a day shape, in like in a BD, and the total span of this drug is 5 to 7 days as in the Clopidogrel. That's why you need to hold this drug before going for cabbage, like 5 to 7 days. So it has a 22% mortality, which was given by the Plateau trial. So it is superior to like Clopidogrel in Plateau trial. Plateau told us that it is actually has a added 22% of mortality benefit versus Clopidogrel. So loading dose is, you know, that it is 180 is the loading dose, and 90 BD is maintenance dose. So and you know about the Clopidogrel's maintenance dose, it is 75 once a day. So the side effects, very notorious side effects of the Ticagrelor is bradycardia. So you need to check when you will give, or when you're gonna load your patient with Ticagrelor, you need to check the monitor for bradycardia, and may your patient would complain about dyspnea if you will give your patients this Ticagrelor. So but these symptoms are self-limiting, so you do not need to stop your drugs because of these symptoms. What's about the Prasugrel? Prasugrel is again, Prasugrel is a bit lethal drug. So what's about this? Is again a P2Y12 inhibitor. It is a pro drug. It is like it is pro drug like Clopidogrel. So it activates in the liver. Yes, its onset of action is 60 minutes. Excuse me. In 60 minutes, it actually blocks 80% of your platelets in the body. So it is actually a very potent drug. But the problem is that it again it has a 12 hour of half-life. That's why 12 to 24 hours of half-life, and 7 to 10 days it's the total lifespan of this drug. And the 30% mortality benefit versus Clopidogrel in Thrombocytopenic trial, which is actually a landmark trial for this drug. And other trials are like Trilogy ACS, which is negative for the medical treatment. If you are going for the medical minimum, like if you are keeping your patient on medical therapy, so you cannot give this Prasugrel because it actually increases what bleeding risk in your patients. So second one is a cost trial. You cannot give your patients the Prasugrel before going to PCI, because for giving the Prasugrel you need to look for the anatomy of your coronary arteries. That's why, because it actually increases the bleeding risk. So the absolute contraindication of this drug is history of cerebrovascular attack or stroke, any stroke, bleeding or ischemic. But the relative contraindicated, like you need to be very vigilant if you are giving the drug in the patient of age more than 75 years and weight less than 60 kg. So these are the actually things which I wanted to share with you guys, because these are actually important things. Please note it down. Please note it down, these things, because these 4 drugs are actually very important, and your supervisor and professors in the ward most of the time ask these things from you guys. That's why I learned by heart these things, and before starting these drugs you need to take care of all these things which I have told you right now. So now what we gonna do, now we will discuss the other drugs which we need to give to our patients, as we have already discussed the AC inhibitor, ARBs, and potassium sparing diuretics, beta blockers, all these drugs. Now the other now we come after antiplatelet, we come at sorry, antithrombotic therapy. Antithrombotic, those were the antiplatelets. Now we discuss the antithrombotic. So obviously the unfractioned heparin is at the top of the list, so it is 10A plus thrombin inhibitor. Okay, it is 10A and thrombin inhibitor. Obviously it is a preferable drug of for the antithrombosis if your patient is going for early invasive PCI or immediate invasive PCI. But you can give this drug for the medical management as well. It is class 1, but obviously you need to put your patient on the continuous infusion, and you have to check the APDT 6 hourly. That's why it is a bit difficult while using this drug for your patients who are at the medical therapy. So the other one we have is low molecular weight heparin, which is actually enoxaparin, and it is again the thrombin inhibitor, but weak thrombin inhibitor. It is weak thrombin inhibitor plus 10A inhibitor. Okay, so this heparin, you can use this drug as well for the PCI and medical management. So if you are using it for the medical management, then you have to give this 1 mg per kg, okay, twice a day, first thing. And if your patient has creatinine clearance of less than 30 ml per hour, then you need to reduce the dose by 50%. Okay, got it? So the trials which actually supports unfractioned heparin is ISIS 1, okay, ISIS 3 and OASIS 6. Please learn by heart all these data, because sometimes your supervisors or professors ask these things from you, that what is the data which actually supports unfractioned heparin in non-ST elevation MI or on ACS. So these are the data actually, the ISIS and the OASIS 6, and the data for the low molecular weight heparin in the non-ST and the ST elevation MI it is et al, Synergy and Essence. Okay, et al, Synergy and Essence. So and what else now we need to discuss here about the direct thrombin inhibitors, because these are the drugs actually, these are again the antithrombotic drugs. Okay, direct antithrombotic or coagulant. So we have discussed unfractioned heparin and enoxaparin. Now we will discuss what DTIs. What is DTIs? The DTIs is like what are the DTIs? Bivalirudin. The IV DTI is bivalirudin. You have to use this drug in what? In the patients who have high bleeding risk. because which trial actually told us about it, that is a ISA react and equity. These were the trial which actually told us that this drug is non-inferior to unfractioned heparin if you are going for PCI. Okay, unfractioned heparin plus GP2B3A inhibitors. Okay, so this is actually non-inferior to unfractioned heparin plus GP2B3 inhibitor if you are going for PCI in all those patients who are going for the percutaneous intervention or early invasive percutaneous intervention. Okay, so and other bival DTI which has a very less role and no data about no data to start in the patients of non-ST elevation MI is dabigatran. Dabigatran is oral DTI. It's the oral DTI. You can only use the dabigatran and those patients who have done with their PCIs plus non-ST PCI with DES plus non-ST elevation MI, and you need to anticoagulate because of any reason like non-valvular AFib. Then the trial which actually supports this thing is redual. Suggest these things yet to be done, yet to be come and sorry, in our guidelines, but redual trial suggests that you can use the dabigatran in the patients whom you have done the PCI with DES and you have to anticoagulate this patient with DAPT. Then you can safely resume the DAPT plus dabigatran, and the trial which actually supports it is redual trial. So now we have 10A inhibitors. 10A inhibitors. So in 10A inhibitors we have obviously fondaparinux. You have to give it sub-Q and it is anticoagulant. Obviously you have to give this in all those patients with the acute ischemic events who are kept or like you are giving the medical therapies and you haven't gone for the intervention in those patients. Then you have you can give fondaparinux in those patients. In the trial which actually support it are OSS 5. OSS 5 actually tells us that you can give fondaparinux in your patient who are on medical therapy for their acute ischemic events, but if you want to go for early invasive or delayed invasive in those patients who are on the fondaparinux, then you have to give what added and dose of unfractioned heparin or enoxaparin. It is better to give the unfractioned heparin if you are going for the PCI, but if your patient is on fondaparinux, then again you have to give unfractioned heparin for PCI or to support your intervention, because you OSS 5 tells us that fondaparinux increases the catheter thrombosis in those patients who are going for the like PCI if they are supporting their PCI with fondaparinux. So you cannot support your PCI as a sole anticoagulant in the PCI the fondaparinux. So you have to give an other anticoagulant agent. What other 10A inhibitor we have? We have what? We have rivaroxaban, So recent, obviously these things yet to be come in your guidelines, recent guidelines, but trials have told us about it. So the Atlas Timi ACS told us that you have rivaroxaban in 2.5 twice a day has mortality benefit in high risk patients. High risk patients like raised TIMI score or high GRACE score. So it is better to keep your patients on 2.5 twice a day rivaroxaban. So it actually gives mortality benefit to your patients. But the data about edoxaban and apixaban yet to become, and there are we have no sufficient data about the edoxaban and the apixaban. So you cannot give edoxaban and the apixaban in your non-ST elevation patient for anything, like for any yes. But if you want to give your patients like the anticoagulation because of non-valvular AFib, and you have done the PCI with your patient to your patients with drug-eluting stent, then yes, you can give edoxaban and apixaban. Okay, I have forgotten the name of all those trials which actually supports the, I think, interest trial told about the edoxaban, apixaban. I don't remember about it, so I don't recalling it. I will tell you on other occasion. Meanwhile, you just need to remember all these things, that yes, if you want to give the anti-thrombotic therapy just for no reasons, like for the plain non-ST elevation MI, that we have the only data for rivaroxaban, yes. But if you want to give your patients anti-coagulation because of non-valvular AFib plus DAS secondary to early invasive PCI, it means now you have to give DAPT with any anticoagulant. Then it is not necessary to start the triple therapy with the warfarin. Yes, you can give what, as I told you, the dabigatran, and second one is the rivaroxaban. So data which actually rivaroxaban, because rivaroxaban is available in Pakistan, so you can safely give this rivaroxaban in non-valvular AFib with all those patients who are on the DAPT because of DAS implantation in their coronaries. So you can give the rivaroxaban, but you have to reduce the dose of rivaroxaban from 20 mg to 15 mg. So you have to give the 15 mg but not 20 mg. You cannot give 20 mg, you have to give 15 mg. Okay, the trial which actually supports it is Pioneer. Please remember all these trials: Pioneer, AFib, PCI. Okay, so because this drug is available in Pakistan, so you need to remember all these drugs and data to support it, because these things yet to become in your guidelines. These are not even in your guidelines. Guidelines still supports, because guidelines are older one, and they still support what, but the use of warfarin. But because as you know that in triple therapy it increases the risk of bleeding. That's why we cannot continue the triple therapy for our patients for like 1 year, because you have to give the DAPT in your patients with DAS. So it is better to start these drugs like obviously we have the rivaroxaban in the Pakistan, so it is better to start the rivaroxaban with the DAPT. And other drugs like protease activated, so we have done the 10A inhibitors. Another drug, Voraxapar, has no role. Voraxapar increases the bleeding risk but no mortality benefit, so it is not indicated. It is a protease inhibitor actually. Protease inhibitor. You just remember the name of Voraxapar if anyone asks you about it. Otherwise, it is not mandatory to remind all these things. Now the important thing we have in our non-ST patients, what is like superior, in medical therapy or invasive. So we just discuss here few trials that supports medical therapy or invasive strategies. And you know that in invasive strategies, as we discussed in our last lecture, that in invasive strategies we have an immediate invasive strategy. Second is delayed invasive, early invasive, delayed invasive, and the fourth one is the ischemia guided therapy, in which you just keep your patients on the medical therapies and you would go for non-invasive investigations. Okay, so trials which actually support medical treatment, these are actually very old trials, because in those time we didn't have good stents and all these latest methodology of doing the interventions. That's why Timmy 2B and Venkish, these are the actually very famous trial which supported the medical treatment in non-ST elevation MI patients. But we have other trials which actually supports your invasive strategies. These are Rita 3, ISAR, Cool, and which are other trials which actually supported your early invasive. Tactus, Timmy 38, Tactus Timmy 18, Tactus Timmy 18, and Frisk 2 trial. Frisk 2 trial actually supports ischemia guided, that if your patient has low TIMI or Gray's score, then it is better to go for the non-invasive investigations. And if you find high risk findings or high risk features on the non-invasive investigation, then it is better to go for early invasive invasive strategies on those patients. So Frisk 2 actually supported ischemia guided therapy. Okay, so and the other trials we have, like the trials on timings of invasive strategy in non-ST elevation MI, that whether we need to go in our patients of non-ST elevation MI with immediate invasive. But if we are going for the immediate invasive, then what type of these patients should be, and what time limits we need to do all these interventions. So ICTUS was now I'm writing here. So okay, ICTUS actually, I just remember these names or write it down in your notebooks, because I cannot keep them here in the board because I have a very small board. So the other trials we have, like Timex, it is positive for the timings. What Timex told us, that it was actually Timex actually told us that if you have to go for early invasive, then it is better to go within 24 hours, and if you are going for the delayed invasive DI, then it is better to go within 72 hours. So Timex actually supports this timings of doing the intervention in our non-ST elevation MI patients. A board trial was negative. It is a newer trial, not a newer trial, but obviously it is more recent than these trials. But surprisingly, a board was negative because it was expected to be positive. But the reason of being it's negative is that they were taking the patients, all patients with non-ST elevation MI within 90 minutes, like primary PCI. Obviously, that's why they were taking the all stable patients within this time limits. That's why that's why that's why this trial became negative, and it gave so many consequences, increase bleeding risk and increase other events. Okay, so that's why abort trial was negative, because they were taking every patient within 90 minutes for the intervention in the non-ST elevation MI. And the other trial which was neutral, it was ICTUS trial. It was ICTUS, but ICTUS was neutral, but the amazing thing for ICTUS was that though all those patients who were in the medical management arm, like those patients who were kept in the medical management arm, they received need of intervention in first year of their life. So if we follow this ICTUS in the later stages, that it actually turned out to be positive, but obviously it is documented as a neutral trial, so you need to remember it as a neutral trial. So ICTUS told us that none of them is non-inferior if you are going for the medical therapy or the invasive therapy, but you need to remember all these things which we have discussed in our last lecture, that we have only 4 strategies that our guidelines have given us. That 4, that was I just want to remind you guys that it was immediate, and you need to follow all these strategies: early invasive, delayed invasive, and ischemia guided. And you know that you need to go in which patients you need to go with the immediate therapy. In immediate, obviously all those patients who are becoming hemodynamically unstable or have ventricular tachycardias or life-threatening arrhythmias like ventricular fibrillations, or the signs, if they are developing the signs of heart failure or new murmur, and or if they have the persistent chest pain despite of medical therapy. So in those patients you have to go for the immediate invasive therapy, and in the immediate invasive you need to take the patient in the cath lab within 3 hours. And all those patients, other than those, if have TIMI more than 2 and GRACE more than 140, then you need to go for early invasive if it is not contraindicated. And all other patients other than this, if they have any multi-comop or any compelling indication not to go the cath lab within 24 hours, because you need to take your patients in early invasive category within 24 hours, then all those patients who are actually applicable to this early invasive, but because of any compelling indication you cannot take your patients to the cath lab within 24 hours, like multi-comorbs, heart failure, like EF less than 30, then you need to take your patients to the cath lab within 72 hours or before discharge from the hospital. Okay, and if your patient has GRACE less than 1.9 and TIMI less than 1 or less than 1, then you have to go for the non-invasive strategies. Then if you will find like high risk features on the non-invasive investigation, then you need to take your patients to the cath lab. So I hope that you will follow me, and please subscribe my YouTube channel and press the bell button to receive the notification of all future updates and my future videos. So God bless you, pray for me, study hard and work hard, and pray for me, nothing else. Thank you, take care.